Good morning, everyone. My name is Dr. Chinmayanand, and I am here with my free course on OBGY. This free course contains high yield MCQs along with its discussion. And from one MCQ, we will be learning 3 to 4 concepts. So, this series of mine is very important for me because I want to give something to my juniors from this free course. So let's start. And before moving to our course, I want to request all of you to subscribe my YouTube channel Earthly Existence, as well as you can follow me on my Instagram handle Earthly Existence. All the details are here. All the details are here. You can follow me on my Instagram handle, and let's move to the question number 1. And we have nearly 1 hour, so let's start. So the question number 1: which of the following is the most common cause of abnormal vaginal bleeding during the reproductive years? So this seems to be a one-liner, but sometimes the MCQ comes in a clinical way and it gets difficult to solve. So the answer for this question is easy and very pretty simple. It's polycystic ovarian syndrome. So most common cause, so in 80% of cases it's polycystic ovarian syndrome. This is the factual data you have to learn. But now let's discuss the algorithm or approach towards the vaginal bleeding, approach towards the abnormal uterine bleeding in reproductive age patients. So we have this approach or algorithm. So I will divide this approach in 2 parts. That is the part A and part B. Part A, the ultrasound will be pelvic ultrasound will be having normal finding. Part B, ultrasound findings will be abnormal, and according to that we will discuss the diseases. So let's move on to the part A. So reproductive aged patient presents with abnormal uterine bleeding. So we have to do CABCDE assessment, that is circulation, breathing, airway, circulation, breathing, airway, disability and exposure, and controlled hemorrhage. So in that case, if the patient is unstable, then we will follow this algorithm, that is control the hemorrhage, stabilize airway, breathing, circulation, obtain IV access, monitor maternal vital signs. So now if the stable patient comes, focus on history and physical examination. We have to focus. So apart from that, SCG, that is the urine pregnancy test, we have to do. If SSG is positive, pregnancy is there, and if negative, we know that it's access for non-pregnancy related causes. So now the main diagnostic we have to do is pelvic ultrasound. So on pelvic ultrasound, what we will see? On pelvic ultrasound, there will be different presentation according to the clinical cases. So let's discuss the first case, which is very we will be first case. If the history is easy bruises, gingival bleeding, heavy vaginal bleeding since menarche, and heavy bleeding with surgery or pregnancy, family history of bleeding disorder, family history that is inherited, it may be a coagulopathy, and we have to do all the labs for the coagulopathy: CBC, PTINR, PTT, and VWF screening. Apart from that, labs will show these findings. We have to find this and then diagnose the coagulopathy. Another case can come is heavy irregular menstrual cycle, weight gain, obesity, acne, hirsutism. It looks like hormonal disbalance. So consider ovulatory dysfunction in this case. That's why hormonal disbalance. So we have to check the labs for TSH, total testosterone, DHEAS. So if according to the labs, also the diagnosis will be different. One, if the abnormal TSH is there and others are normal, then thyroid disorders we have to rule out. Then apart from that, if the normal TSH, elevated total testosterone, and elevated DHEA is there, then it's a polycystic ovarian syndrome, which is 80% cases are with this syndrome that causes bleeding, heavy bleeding. So this this topic, polycystic ovarian syndrome, I have further discussed in this lecture, in this high discussion also, and we will be solving that MCQ later. So for your factual data, I have giving this, and it will be easy for all of you to solve the clinical cases. Then third, if the regular menses are there and heavy vaginal bleeding, intermenstrual bleeding is there, then we have to go for endometrial dysfunction and other causes, like if the patient takes IUDs, hormonal contraceptive, anticoagulation, then iatrogenic cause will be there. It's iatrogenic cause. And apart from that, after assessing common cause of abnormal uterine bleeding, we have to consider other causes. That is, in negative history, we have to take possible can be cesarean scar defect, atrovenous malformation, and sarcoidosis. So this is the part A. That was the part A, guys. So let's move on to the part B. Part B. So let's move on to part B. Part B is very, very, very important because abnormal findings. In this case, we will be having 4 cases. First, if there is a postcoital spotting is given, intermittent intermenstrual bleeding is given, and on physical examination normal size or shape of uterus is there, plus minus polypoid mass. If they say polypoid mass at cervical os, the direct diagnosis will be polyp, that is cervical polyp. Consider we have to polyp, and then we have to see one more thing on ultrasound will be there, thickened heterogeneous endometrial lining will be there. So that's important, and the polyp will be diagnosed. So what we have to do in the polyp case, excisional biopsy, polypectomy, and most of the time it's benign and benign, and we have to diagnose it as endocervical or endometrial polyp. So this is diagnosis. Then apart from that, one more diagnosis, that is heavy vaginal bleeding is given, dysmenorrhea, that is heavy periods are there. So diffusely enlarged globular. So if they say diffusely enlarged globular and tender uterus, we have to go towards adenomyosis. What is adenomyosis? In adenomyosis, there is a abnormal development of tissue in the myometrial area. That is, a heterogeneous myometrium will be there, and myometrial cyst will be there, asymmetrical myometrial thickness will be there. So we have to diagnose this. So apart from that, third, if the heavy vaginal bleeding, pelvic pain or pressure, and enlarged uterus with irregular contour, and ultrasound shows greater than 1 myometrial mass, then it's a leiomyoma. It's leiomyoma. Then apart from that, fourth, if age groups is given, we have to always look for the age and go and approach toward the case. So if 45 gets better, if the patient is 45 or greater than 45, chronic ovulation is there, unopposed estrogen is there, high estrogen is there, obesity is there, unremarkable findings or physical findings are there. Ultrasound, no myometrial abnormalities are shown, and thickened heterogeneous endometrial lining, again heterogeneous endometrial lining. If they are giving here endometrial lining, they are saying, then in that case you have to go towards endometrial diagnosis, and two diagnoses for endometrium are endometrial hyperplasia, endometrial cancer. So consider malignancy in this case. Endometrial biopsy or hysteroscopy should be done. Biopsy, crowding of endometrial glands within the stroma, and nuclear atypia will be there. That will be endometrial intraepithelial neoplasia, hyperplasia. So here is this. So what will the nuclear atypia? And loss of perpendicular loss is there, loss of oriented or basement membrane, gland show architectural complexity is there. Apart from that, there will be, apart from increased gland to stroma ratio will be there, gland to stroma ratio, that is glands will be more and stroma will be less, then it's endometrial hyperplasia, intraepithelial neoplasia. Then apart from that, and if the biopsy gives us a crowded endometrial gland like this, endometrial glands are crowded like corkscrew appearance little bit, and if here not differentiated solid shade, then if it's poorly differentiated, grade 3. If it's moderately differentiated or grade 2, well differentiated is their grade 1. So well formed glands will be seen. Apart from that, nuclear atypia of course will be there, and significant glandular irregularity will be there. So from this two charts you can solve at least 6 to 7 questions, and that's it for this first question. So I hope it's very easy and was fruitful will be fruitful for you. Now coming to the question, 40-year-old female presents with menorrhagia. She undergoes a transvaginal ultrasound for that demonstrated enlarged uterus with heterogeneous myometrium. They are saying not endometrium. So first history clincher, then Venetian blind artifacts, that's important, and tortuous vessel through the abnormalities on a color Doppler. What is the most likely diagnosis? Heterogeneous myometrium, in which case we see in adenomyosis. So in leiomyoma, no. In adenomyosis, yes. Adenomyosis, endometrial polyp, no, because there is no given polypoid mass or something. Endometrial hyperplasia, no. In that case, something else should be given. Leiomyoma, no. So adenomyosis is the easy. So from that table you can solve this question easily. Now coming to the next question, that is 32-year-old G5P1 presents for her first prenatal visit. A complete obstetrical, gynecological and medical history and physical examination is performed. Which of the following would be an indication for elective cerclage placement? Elective cerclage placement must be done in case of, like, if cervix is not potent, uh, cervix is not potent. So in this case we have to first learn the abortions type. Abortion types are very important to learn to solve this question, because without a definition of abortion you can't solve this question. So let's move on this table. So we have types of miscarriage or abortions. Pregnancy loss occur at less than 20 weeks of gestation is abortion, and WHO says fetal weight less than 500 gram, nearly 22 weeks. And now let's come to the types. We have 6 types. First, complete. First, complete abortion, number 1. Then incomplete, threatened, missed, inevitable, and last, recurrent. So while solving this, we have to see for this characteristic pelvic exam and ultrasound. So first, if bleeding and complete passage of product of conception, complete. In pelvic exam, cervix open or closed. It might be open or closed depending on stages of abortion. Empty uterus will be there. It means complete abortion. Incomplete, heavy bleeding, which includes passage of some product of conception, some. So incomplete. Cervix will be dilated, of course, and retained tissues will be there. Threatened, slight vaginal bleeding, abdominal pain may be present, intact membranes and cervical loss, of course, closed and threatened. Viable intrauterine pregnancy detected. So missed, in case missed, there is simple thing, miss means something is missing. So no cardiac activity is missing. Apart from that, it's a non-viable pregnancy, no fetal cardiac activity, empty gestation sac. Cervix will be closed in missed abortion, often asymptomatic. Recurrent, that is greater than 3. Spontaneous abortion, in that it may be missed, it may be inevitable, it may be incomplete, or it may be complete, depends on the type. Pelvic examination will be there. Empty uterus and uterine anomalies may be evident. Inevitable, that is vaginal bleeding and abdominal pain present. Membranes may or may not be ruptured. Cervix will be dilated. Pregnancy may be viable or non-viable at the time of presentation. So this chart will help us to solve this question. So first, this question is based on the definition of abortion. So let's start. Let's see the option. 3 spontaneous in the first trimester abortion, no. Weaned pregnancy, no. Then 3 second trimester pregnancy losses without evidence of labor or abruption, yes, possible. Second trimester less than 22 weeks, less than 20 weeks. They are saying according to the definition less than 20 weeks. So it's second trimester case. So pregnancy loss without evidence of labor or abruption. The options are not significant, so just save our time. Let's move on to the third question. Third question is fetal death at 15 weeks. Fetal death at gestation, 15 weeks of gestation without expulsion of any fetus or maternal tissue for at least 8 weeks. Match description. So there is already death happened, so missed. So it's death has happened, so cardiac activity will be absent. So it must be a missed abortion. That's it. So let's move on to the next question. This is the high question again. Following statement false regarding this condition. Firstly, this condition is Acanthosis nigricans. So in this case, we have to, this is true or false statement. We have to say which is true, which is false. So they are asking regarding false statement. So topical steroid are mainstay of treatment in Acanthosis nigricans. No, it is not. We'll discuss which is the treatment. It is commonly associated with insulin resistance. Yes, it is. It is often linked to obesity. Yes, true, it is. It associated with PCOS. Yes, it is. So let's Acanthosis nigricans in this treatment is a very mainstay of treatment, involves addressing underlying cause. So in this case, we just treat the underlying cause and disease will get okay. So that's the important thing. Mainstay of treatment is this. And is a condition is dark velvety patches of skin that usually develops in body folds and creases. It's often associated with insulin resistance, obesity, and condition like PCOS. So this is the one more question you've done. This is a very high yield question recently asked. Then fifth question, bacterial vaginosis. These infections are very important for this examination, especially FMGE, because a lot of time they ask it and we get confused here and there. So bacterial vaginosis, to be diagnosed in a patient, several findings must be present. Which of these findings most likely indicate a concomitant infection and a need for additional testing? So bacterial vaginosis. So clue cells on saline wet mount vaginal discharge, it is present, but they're asking which of this most likely indicate a concomitant infection, that is one more plus infection we have to find out. So cell mounts, it's already seen in, like, we see this in BV, bacterial vaginosis. Gray discharge also we see there, vaginal pH also we see there, and so WBC on the wet mount, it shows like it's Trichomonas or other infection can be there. So this is the answer. Let's discuss its algorithm or its explanation. So vaginal yeast, that is thrush we call. In vaginal yeast cases, take white or curdy. So curdy means vaginal yeast infection, white color, usually no odor, and 3.8 to 4.5 itching. pH. Bacterial vaginosis, we have thin and milky discharge. Texture will be thin and milky. White, off-white, or gray. Gray is a histologic clincher. Fishy smell is a histologic clincher. Greater than 4.5 pH is a histologic clincher. Then we have Trichomonas. Trichomonas trick, thin, again foamy and frothy is a histologic clincher. Yellow to greenish is a histologic clincher. Foul, moldy smell will be histologic clincher. Greater than 4.7 we can see is a histologic clincher. So apart from the urinary tract infection, in this case we know E. coli, Klebsiella, and other proteus are like causing agents. So texture any, not applicable, not applicable any. So now coming to the physical symptoms. Physical symptoms in all of them: itching, burning, itching, burning, itching, burning, and pain. These are most common. But in Trichomonas there will be pain when urinating, and remaining are same. So it's very easy. You should know Trichomonas thing, pain while urinating. Others, there is itching, burning, pain will be there. So no need to go in deep for this. Then coming to the another slide of this, bacterial vaginosis, we will see gray or milky discharge. This is gray or milky discharge. Fishy odor will be there. Positive amine test, whip test we have to perform here. So what we do in this test is whip test. We we take a discharge on a slide and put KOH, and there will be fishy odor will come due to amine. So positive amine test, that's why we do this test, whip test. And whip test, there is one question also this can be asked on the whip test. You have to learn this 10% potassium, this MCQ asked, and pH you have to learn. So now coming to the another one, that is Trichomonas. Trichomonas, yellow green frothy discharge, as we have already discussed. Strawberry cervix is a histologic clincher for this. Foul smelling will be there, and flagellated protozoan. Flagellated protozoan is given, slight hint of it also given. So we have to think about Trichomonas, and we have to save our time because we have section bounded question paper later. Now infection, yeast infection, mainly Candida albicans. It's a curdy white discharge, cortices appearance, pseudohype. It's in microbiology also this question can come. Pseudohype is seen on slide or something, so you can mark there also. So it's a multivariate question. Then we have this, these are the clue cells, these are Trichomonas, and this is vaginal Candida. So you have to learn, you have to see this species, and slide also sometime images will be there, and it will be easy for you now. So no need to worry about this. About this PDF. I will be sharing this PDF on my Telegram group or Telegram channel. So just wait. No need to write anything. Everything will be given. So now this is again the table same. Culture. You have to see the culture. Normal vaginal flora. Not usually perform bacterial vaginosis, Candida and other or Candida species. Trichomonas and vaginalis, pus cells, and all that stuff. Now coming to the next question. There are several equally effective treatment options for bacterial vaginosis. Certain patient characteristic can determine which treatment option is best. For example, if the patient is in her first trimester of pregnancy, which of the following is the most appropriate treatment option? So first, in this case, we give Metronidazole is a drug of choice. So how it comes? So we have to discuss it. Let's see. So in BV, bacterial vaginosis, tricho, and Candida, we have two groups: non-pregnant, pregnant. In non-pregnant bacterial vaginosis, we give Metronidazole 500 mg BD 7 days or clindamycin, but drug of choice is Metronidazole. Trichomonas, again same, but or 2 grams stat can be given. Candidiasis, oral fluconazole, it's 150 mg stat. Now in pregnancy, bacterial vaginosis as well as Trichomonas vaginosis, Metronidazole is given, but there is a slight difference. That is, in first trimester we give vaginal Metronidazole, in second and third trimester we give oral dose. So dose is same for both. Then candidiasis, oral fluconazole contraindicated in pregnant women. pregnant women. Then topical clotrimazole we have to give in case of candidiasis. So partner treatment need in these two diseases, that is Trichomonas and Candida. Next question. Which of the following finding on physical examination is most likely to indicate that Trichomonas is cause of patient cervicitis? That's important. Trichomonas. I previously have discussed there is something called as strawberry cervix. This question is related to this. So let's see. Cervical motion tenderness, no. PID, in PID we see an ectopic pregnancy, we see this. Fever, no. Punctate hemorrhage on cervix, yes, of course. This is only the strawberry cervix. So this is the answer. Vesicle or ulceration of vulva, no. So let's just no need to discuss, we have cleared that already. So these are the two infections, more two infection, chlamydia or gonorrhea. We have to find both are due to unprotected sex. Strawberry cervix is also seen in chlamydia, so we have to be careful while seeing the reading the case. So bleeding with sex, bleeding between periods, scanty water, transparent discharge, scanty discharge with foul smell, minimal burning with urination, minimal urethral swelling and redness, minimal watery and transparent discharge. In this case, there will be abundant yellow thick, abundant. When they say abundant means gonorrhea, and yellow and thick is gonorrhea. And when this is scanty, it's a candida. This is a scanty for candida cervicitis. So apart from that, two more questions I have to add here. Gonococcal separatus. Gonorrhea has a medium called as thiomartin media, and so chlamydia has McCoy cell line. So two more MCQs. Apart from that, most common spread route is one liner ascending with sperms. Most common site endocervix is again one liner. Investigation of choice one liner NAT, that is nucleic acid amplification test. Then we have another for treatment of chlamydia or gonorrhea. For gonorrhea, there is if whether the patient is pregnant or patient non-pregnant, we have to give injections, ceftriaxone 150 mg IM. This is an important single dose. One more MCQ. Then chlamydia we treat in non-pregnant by doxycycline 100 mg OD for 7 days. Doxycycline is contraindicated in pregnancy. Then azithromycin 1 mg oral single use in pregnancy should be given. Complications of these both will be PID major due to ascent of infection. Then perihepatitis, that is Fitz-Hugh-Curtis syndrome. One more one liner. It is asked in past FMGE exam as well as NEET exams. Now this management sexually transmitted disease is very important table. You should learn by heart this because it will be asked in PSM as well as OBGYN. So we will discuss this in PSM lecture because that's very important there. Because it's according to PSM they have created this. Now supportive treatment in this case we have abstinence of sexual activity for 7 days, condom contraceptives, and partner treatment. Cervicitis and PID not indicated in vaginitis. Vaginitis means these two. Then we have number 8 question, that is 29-year-old woman present to the fertility clinic with inability to conceive for 3 years. She and her husband live together and have been married for 4 years. They are not using any contraception at present and are sexually active. Her menses are at 28 days interval, so it's regular. Her husband is a cyclist by profession. The initial test that should be advised to this couple are initial tests. So let's read out the option. It's easy, I guess. Semen analysis, yes, we can do. Chest X-ray, no need. Mentox, no need. Semen analysis, tubal patency, yes. Ovulation test can be done. Ovulation, these are rule out and rule out. So it's option B. So it's very easy, basic. So just read the explanation here and that's enough. So now question number 9, review the following histosalpingogram. Very important. This kind of questions are asked in NEET PG as well as FMG. So what is this? Banana. This is a banana, means it's not banana, it's image, and this banana image is like banana. We say this is banana unicornate. For unicornate uterus we use unicornate uterus. It is. So this was many times they have asked. So this grading no need to learn. The basic thing you have to learn is this images, because imaging are very important. Normal or arcuate uterus look like this. Septate look like this. Septate will form V, and bicornuate will form Y. So that's important. And bicornuate with cervical septum also, but Y it kind of like this. And unicornuate will be a banana. So this is very important. Mullerian duct anomalies, role in infertility and pregnancy. Now coming to this question, identify the type of chrionicity based on the image. So this is very important. Dichorion means two chorion, monoamniotic, one mono, one amniotic pregnancy, that is one amnion. So let's see, there are two umbilical cords, and there is a single placenta, so it will be monoamniotic pregnancy. And chorion is also a single, there is no division in between, so it's a monochorionic monoamniotic pregnancy. So let's read out this. So explanation: the provided specimen illustrate monochorionic monoamniotic pregnancy. A single placenta is origin of two umbilical cords. Here in this case, as we have seen, indicate monochorionic condition. There is no amniotic membrane between the cord and the placenta. So incorrect options, these are option A, that is dichorionic diamniotic, where each tween has its own chorion, that is two chorion, but shares a single amniotic sac. Then MCDA, that is pregnancy have single placenta but two separate amniotic sac. The image doesn't match this description as there is no, okay, whatever. Diamniotic dichorionic, that is must have two placenta and thick intervening membrane composed of amnion. So these are the dichorionic diamniotic, monochorionic diamniotic, monochorionic monoamniotic, and monochorionic monoamniotic conjoined twins. This is very important. Apart from that, this table is very important. You have to see from this, the only thing is very important is approximate incidence diamniotic dichorionic single, and can be asked. Apart from that, approx mortality will be more in the 40 to 50%, that's monochorionic monoamniotic. Again question, this is a question that's important. And apart from that, there are two slides very important. We have lambda sign. Lambda sign will be seen in diamniotic dichorionic type, that is like this, like so that will be seen like this. So lambda will be seen here, we have seen, so this like this. And apart from that, diamniotic monochorionic and monochorionic monoamniotic T sign will be seen like this. So these are the history clincher. Apart from that, coming to the next question, a decision is made to perform a episiotomy to facilitate the progression of labor. An incision is made from the posterior midline of vulva towards the anus. Posterior midline of vulva towards the anus, so towards the anus, slightly towards the left. So this is the midline in case, and this is, so they are talking about mediolateral episiotomy, and this is median. Which benefit does this kind of incision offer over a simple midline incision? So why they are asking why mediolateral episiotomy is superior. So mediolateral, why it's superior, and midline. So we know that in midline incision, easy repair is there, agree with midline, and quick healing in midline is there, less blood loss in midline is there. But the problem with midline is there less extension, that is more extension in midline. Here I will explain, let's wait. So this is the midline episiotomy. In this case, there is a chance of more extension and anus will get cut also, so there will be chance of more, that is, it will not be cosmetically good also. And apart from the mediolateral, even if we cut, but there will be lesser extent, the less extension to the incision. So this they want to ask, and this is asked question in recent FMG as well as NEET PG exam. So you have to go through it and read this explanation again and again. Then now coming to the 12th question, a 30-year-old patient visited the antenatal clinic at 14 weeks of pregnancy for routine checkup. On her regular antenatal panel, she tests positive for HBsAg. Which of the following is true about her condition? Significantly increased maternal morbidity? No. HBs and mortality is less? No, not an option. High risk with IUG and IUD? It's a risk, but it's not high risk. It's again option are wrong. Then HBs is the first serological test. Yes, it is. Lamivudine, is it? No, it is tenofovir and other drugs. Another drugs are there. So let's discuss drug. So what we have is Chalmydia and tenofovir is used. This is the correct answer, and this is this is one more fact. And IUGR, it's not associated with increased risk of IUGR and significant increased maternal mortality, morbidity? No, not a cause. And of course, HBsAg is a marker of unprecedented increase of transaminase level. Patient is asymptomatic. Oftenly, diagnosis is used to indicate a routine antenatal screening. So this is done. Now, which of the following is a physiological change in pregnancy? Physiological changes in pregnancy, most of them they ask. So in pregnancy, what occurs? uh, you have to learn this chart. I have given this chart. You have to learn plasma volume increase, blood volume increase. After reading this chart, everything will be sorted. So let's see the, if I read those options or that chart, it will be time wasting for us. So it's not a physiological change in pregnancy. So increase SDP and DB after 6 weeks. It's not increasing plasma volume and RBC. Yes, it is, because pregnancy, it's adaptation for pregnancy. A mother needs to feed a child. Apart from that, fasting hypoglycemia and postparental, yes, fasting hypoglycemia, because a fetus feeds on mother's energy. Then postparental hyperglycemia will also be on a female, of course. Peripheral resistance to insulin leading to hyperinsulinemia. Yes, it is there. Peripheral resistance will be there. That's the adaptation for pregnancy, because what happens, fetus needs more food, and that's why if there is resistance, peripheral resistance to insulin, hyperinsulinemia will be there, and whatever the carbs or whatever the food will be taken by a child, and insulin will not act on that. So that insulin should not act, and there will be hyperinsulinemia, and there will be refractory effect of this. So that's why. So this is again factual question is this. You have to learn this. There is no increase in, this is very very important, recently asked NEET, PG and INICET question. Now coming to the another question, that is, a 14-year-old female with acute retention of urine complain of cyclical pain in abdomen. On exam, tense bluish. Whenever they say tense, means something related to hymen. They are asking swelling in the PR suprapubic. So it is directly cervical agenesis. No. Longitudinal vaginal septum. No. Imperforate hymen. Yes, it is. Transverse vaginal septum. No. So let's see the hymen types. So this is imperforate hymen, and in this case you will say tense bulge. And remaining are this annular hymen, septate hymen, cribiform hymen, and this is introitus hymen. So this you have to see which of the following, and that, by the way, that question is recently asked in INICET. So it's a recall question. So you have to see this because questions do repeat. Which of the following is not a part of AMPSL? This is very very high yield topic. Most of the time it's asked, and so no need to do this MCQ wrong. Very very easy. So before that, moving to, we should know this factual data. That is administration 1, administration of uterine oxytocin agent within 1 minute after birth of baby and ruling out of the presence of another baby. So it's shown in this. Then controlled contraction shown here with countertraction to support of uterus. Third, uterine massage after delivery of placenta should be done, shown here. So now coming to the question, uterine massage, yes we do. Delivery of placenta, yes we do. Bimanual compression, we don't do that. Bimanual compression we don't do. And administration of oxytocin we do. Yes, true. This is a false. So this is a false statement, and this is the answer. Now coming to the another question, that is a female 40 weeks gestation progressed spontaneously, and she is second stage of labor for 2 hours. There is a fetal bradycardia. She is having 4 contractions per 10 minutes at plus T station. Whenever the stations are given, probably the questions are regarding the instrumental delivery. Suture is in AP, caput is present, and next step is management. So before knowing this, you should know these slides. Instrumental delivery, in that case, station should be greater than equal to 2, and instrumental delivery are done in second stage of labor, prolonged, then fetal distress. Then we have to cutting the time of second stage of labor, we do this instrumental delivery. Maternal exhaustion, heart disease, and PH, in that case we have to cut the time. Forceps, this mnemonic is very very important. Forceps, that is favorable position. Sagittal suture in AP should be there. Os dilated should be there for this forceps delivery. Then ruptured membrane should be there. Contraction positive, and consent should be taken. Episiotomy, and engaged head, empty bladder should be done, and pelvic should be adequate. So next is this types. We have forceps delivery. Forceps, again that mnemonic you have to learn and see it because it's very important. Then vacuum assisted delivery, second type. In this can be used it's used in incomplete cervical dilation greater than equal to 6 cm. Non-rotated head should be there, and vertex presentation will be there, plus full cervical dilation, rotated head should be there. Decrease maternal effort, to decrease maternal effort are there, then we should do vacuum assisted maternal heart disease, but forceps is preferred over vacuum always. So these slide. And now coming to this, So which forceps will be used, they are asking. Apart from that, we know now this is the instrumental delivery mental delivery question. But apart from that, we should know the forceps, because are we going to do ventos or vacuum assisted? No, in this case, because +3 suture and AP, so it follows a forceps mnemonic. So we have to go for forceps. So which forceps now? So which forceps? These are 4 forceps, and from that, Wrigley's or outlet forceps, it's asked many times. Then we have Keeland forceps, it's outdated, sliding lock it has. Then we have Piper forceps, longest forceps, and coming head for breech presentation we use, and Tucker McLean forceps, only forceps with solid blade it is. These we don't use. Now remaining the outlet. Why I have taken this question during my exam also, there was a question regarding outlet forceps, and recently this question also asked in INI-CET. So outlet forceps is the answer. So that's it. Moving on to the next question. So this question, 26-year-old female complains of heavy vaginal bleeding. So this question should be solved according to our AUB approach. She delivered a male baby 3 days ago. She denies of any pain or fever. Fever is not there. So a diagnosis of postpartum hemorrhage is made. Postpartum hemorrhage diagnosis already made. So which of the following is not cause of such postpartum hemorrhage? Discussing further in this lecture, but first let's see the option placenta previa. Placenta previa and PPH, there is no relation. So it's APH, antepartum hemorrhage. It happens. Written parts of placenta, it's in PPH. Endometritis with PPH, of course. Placenta polyp with PPH. So this is a simple fact-based question. You should know the risk factors for PPH, and then you can solve this question easily. So placenta previa. Another one thing, what I can say to solve this question, because this is asked very many times, and ICT, FMGE, and NEET. So what previa? So simple, I am giving previa and P, APH, but A is the first, that is capital letter starting. So first, so give previa. So in that, like this also you can learn it, but I'm not saying you to learn like this, but still if you can't remember stuff, then previa. So AP, so first letter is A, so previa. Then we have this explanation, placenta previa, a condition where placenta partially or completely cover the cervix. So let's discuss this condition, placenta previa, and this is the explanation you should read. Then 2 cases, very important, placenta previa A and placental abruption. These are very important. So what are the key features to diagnose these both condition and make a differential diagnosis? So placenta previa is a painless condition. Abruption placenta, painful condition. Bleeding always revealed, here revealed, concealed or mixed. Bright red colored in previa, dark red color bleeding in placenta abruption. These are a history clincher. And bleeding will be out of proportion in abruption. It's a heavy bleeding there. Height of uterus will be equal to, it's proportionate in this, and it's not proportionate. Then soft and relaxed, maybe tense and rigid here, uterus. Apart from that, you should see the placental lower segment. Previa in lower segment, abruption upper segment. So this is, apart from that, I'm giving some easier things. So this is the slide you should learn and see APH, placenta previa, APH. This is my Insta feed, and it's very easy. Even if you don't remember the other stuff like differential diagnosis I have made before, so this slide, even if you learn slides, it's easy for you. These are the grades you can learn. Grades can be asked. So grade 1 minor, that is low lying placenta but not reaching the internal os. Then we have edge of the placenta reaches the internal opening, that is second grade 2 marginal. Then we have partial, that is lower edge of placenta partially covers opening. And then we have grade 4, that is completely covering. Then this is the again, this is the bright red. These are bright red, previa, dark red, abruption, pain, abruption, previa, painless, and fetal distress in abruption will be there, and apart from typical, no fetal distress. So let's come to the question. There was fetal male baby delivered 3 days ago, and everything is correct. So let's move on to the next question, I guess. So next question number 20. Question number 20, 18-year-old female presents with a primary amenorrhea with breast tanner, breasts are present, and normal secondary sexual characteristic or normal FSH level 5.3 international unit and LH is 12, karyotype is 46XX. So what is the diagnosis? They have given karyotype and primary amenorrhea with breast tanner stage 4 and normal secondary sexual characteristics. So it seems something is related to agenesis or agenesis diseases. So Calvin syndrome. So let's see. Mullerian agenesis. Yes, it is possible because karyotype matches. Apart from that, breast tanner, breast or vagina, primary amenorrhea, and secondary sexual characters are normal. So it has like it's positive for this disease. Then Calvin is not because anosmic symptoms are not here, and androgen insensitivity. No, there is no related to androgens. Anything is not given. So wrong. Gonadal dysgenesis. It's not there. But in dysgenesis, we see Down syndrome and other things. So, but here is a karyotype is like this. So let's discuss this. Mullerian agenesis, 46XX in Mullerian agenesis, androgen incident 46XY. Apart from that, for diagnosis of this condition, breast will be present in both conditions. Axillary pubic here, this is a very important. That is a secondary sexual character is normal in Mullerian agenesis. Here in androgen AIS, that is androgen incident syndrome, it is absent. Apart from that, other things, there is no uterus in Mullerian dysgenesis. Mullerian agenesis, sorry, and here the high testosterone level needs orchidectomy in AIS. So this table you should learn, and you have to solve this question accordingly. So now this again one more table is very important. You should learn this. Now Calvin syndrome. Calvin syndrome I am discussing because it's also asked a lot of time. Calvin syndrome is a rare genetic disorder that affects the development of hypothalamus and osmia, absence of the sense of smell, then delay or absent puberty. Then we have punchline in this Calvin syndrome is this combines an impaired sense of smell with a hormonal disorder that delays or prevents puberty. Now this is the mnemonic for Calvin syndrome. So anosmic. So first is anosmia, then no menstruation will be there, oligospermia, sex hormone deficiency, midline defects, inherited it will be, and cryptorchidism will be there. So now this is the diagram, very important and very easy. And so why defect in neurons will be there? Two types of neuron. First, olfactory neuron, that will cause olfactory neuron that will be causing hyposmia, that is loss of smell, and anosmia, that is complete loss of smell. Hyposmia, decreased sense of smell. So now GnRH releasing neuron problem is there, that is decreased GnRH, that is decreased LH and FSH will be there, low gonadal function will be there, and testosterone will decrease, progesterone will decrease, and that will result into another symptoms. So now this is gonadal dysgenesis chart. You have to learn this, very important. In this there is complete gonadal dysgenesis, partial gonadal dysgenesis according to the karyotype you have to learn, and other defects these are also asked. And in this Turner syndrome is asked FMG question, so you should learn that. Klinefelter, you should learn that, especially karyotype. So 45X, that is 45X0, that's a Turner. 47 or XXY, that's a Klinefelter, and this is mixed gonad and chimeric. So you have to learn this. This chart is very important. I will be sharing PDF, no need to worry, on my Telegram group. Now 21. This question is MTP related. 21-year-old, 10 weeks pregnancy is done by medical method by using intrauterine. So which done by which conditions, like by which method we are doing this, we have to tell. So intrauterine hyperosmotics, no, not given. Dinoprostone, not given. 21-year, 10 weeks pregnancy, no. Osmotic infusion, no. M&M, that is Mifepristone and Misoprostol. Yes, it is given. This is the explanation. So Mifepristone and Mifepristone should be combined in this case. That combined effect initially. So Mifepristone terminates pregnancy. It's anti-progesterone, inhibits progesterone, and that inhibits progesterone semantic effect will lost a hormone required to keep pregnancy going. Misoprostol, prostaglandin, its analog induced contractions. So it should be, so progesterone effect will be from pristone and contraction effect from prostol. So this combined will give a safe effect, and that can be used regarded as safe and successful pregnancy up to 10 weeks of gestation. 22 weeks of gestation, unmarried 14-year-old girl who is rape victim come at your clinic, medical termination. What is true for medical abortion? So this is related to law of medical abortion. So we should know this. MTP can be done in rape victim till 24 weeks. Yes, in case of rapes, it's extended now. Only one doctor, no. Two. Only done if risk of life, no. MTP can be done after permission of medical board. Can be done. It's not can. We have to, like, MTP should be done after permission from medical board. So that's why this incorrect option probably. So let's discuss now. This is the discussion regarding the gestational age. Up to 10 to 12 weeks of gestation, medical abortion is permitted in many states. The limit may be increased in case of rape or incest, but often not longer than 24 weeks. But less than 20 weeks we can. So question is solved. Legal and medical considerations are there, so you have to read it thoroughly, and its proper explanation I have given here. So apart from that, compared to previous stages, a medical abortion at 22 weeks of gestation typically follows a distinct strategy. Is there a combination of drugs, potential surgery would be needed depending on the exact procedure and the resources that are available. In conclusion, medical abortion is normally allowed up to a certain gestational age, that is 24 in rape victim, otherwise in 10 to 12 weeks in states they are doing. However, the legal framework may differ in case involving rape, particularly beyond the standard limitation. Extra measures or permit may be requiring. So this question is very important. A lot of time asked. This is asked recently in NEET PG 24. So now coming to the next question, we have a G5P4 woman comes for routine sonography for first time. She has early 4 daughters and want boy this time. Asks for sex determination, which is illegal. To bide to above depicted guideline, what will you choose? So option 1, will check routine ANC and sex for developmental abnormalities and do not reveal a gender. Yes, you should not reveal a gender. So now for now this is a true correct option, I guess. Will check routine ANC and sex abnormality. Do reveal gender of patient. No, wrong. Do reveal gender. No, if girl, no. Check only routine ANC. Do not check the sex. No, we have to check the sex because some diseases are genetic diseases are common in male, so we should see the fetus, it's female or male, and then we can rule out other diagnoses also. That's very important. So this is the answer. So now this is the explanation. You should read it very well, and this question is very easy, but you need to read this explanation once before going to exam, because sometimes there may be twists and turns in questions. So this is NEET PG 24 recall question. So this can be asked again. Now 24, a pregnant female comes to gynecologist who sent her for ultrasound. On ultrasound there is pregnancy noted with 1 month difference in ages of fetus. 1 month difference is there. Difference. Which of the following is true? So fetation, fecundation, supposites, and posthumous. So in fetation there is a difference. It's 2 ova at different time. Fertilization. So this is the answer for sure. So fecundation at the same time, 2 ova. Suppose it's a fictitious pregnancy, it's not, and posthumous, it's a child from another lineage that they pretend to be from the, like they pretend false that child from another lineage, like others' child, they tend to make their own child, like that stuff happens in posthumous. So explanation for this is here. You should read it. Apart from that, basic is superfecundation definition. This is asked in NEET PG question. This is NEET PG 24 question. So FMG, it can get repeated. So first, 2 ova which have been discharged from ovary at the same period but separated by 2 coitus shorter. This is fecundation. And fetation, it's second ovum in a woman who is already pregnant. So there is a time difference between. So learn this table, go through it once, that's more than enough. I'm not gonna read out it because it's you have to do it on your own. Then next, 25, 32-year-old female at 36 weeks of pregnancy present with BP 170 and 100 mmHg. Visual disturbances are there, headache, urine protein positive 3. What is the next step? So this seems to be an eclampsia case, pre-eclampsia case, and what's the diagnosis? And they're asking what's the treatment. So Okay, let's solve this question. Preeclampsia 170, and it's very bad condition because 170 by 100 mmHg for visual disturbances and headache, urine protein. So it's I'm marking it as, of course it comes under category of preeclampsia, but it can be a impending eclampsia also. That is something gonna happen bad in coming future. So this can be between these two. So they didn't ask us diagnosis, so no need to worry about diagnosis in this question. That's main thing. But the treatment, we have to do treatment here. So in this case, treatment. Now for this high blood pressure, we have to give labetalol. So labetalol in every option. So labetalol is for sure. Then magnesium sulfate, yes, we have to give it. Magnesium sulfate we have to give. Then expedite pregnancy, expedite delivery. So for this expedite delivery, that is termination of delivery, we should go to see the period 36 weeks. So before solving the question, let's come to the slide. Why? So condition, if these are the condition and termination of pregnancy, 37 weeks and mild preeclampsia is there, then termination of pregnancy we can do. Severe preeclampsia is there, 34 weeks, we can do termination of pregnancy. Eclampsia, in case of eclampsia, impending eclampsia, HELP syndrome, PIH, fetal distress, PIH abruption, we can do immediate termination of pregnancy irrespective of gestational age. Chronic hypertension, 37-38 weeks. Chronic hypertension with superimposed preeclampsia, 37 weeks. And apart from that, we should know this differences. Mild or moderate preeclampsia, that is BP should be greater than equal to 140/90. Proteinuria with the headache and visual disturbance will do. Headache and visual disturbances, visual changes will be there in severe preeclampsia also, but here proteinuria will be greater than 5 gram per 24 hours and greater than 160 by 70, 160 by 110 mmHg. Oliguria will be there, and increased serum creatinine, pulmonary edema, thrombocytopenia, that is intravascular coagulation, that is, and evidence of fetal compromises will be there. Eclampsia, all of the following severe preeclampsia condition plus evidence of convulsion, seizures or coma will be there. So for seizures and coma, convulsions, so in this case, if they would have given plus another findings like convulsions and other things would have given, then it's a case of impending eclampsia. This question is a little bit incomplete, but still there is basic answer. This IV labetalol MgSO4 expedite pregnancy. Without, we don't need to look for 36 week. Labetalol and delivery, no need, we can't do. It's very risky at 37 weeks. No, we can't wait. IV labetalol, dexamethasone, immediate termination of pregnancy. No, dexamethasone should be not be given. And another option is also wrong. So learn this chart. Apart from that, read eclampsia, severe preeclampsia and moderate or preeclampsia. So impending eclampsia case it was. So I have to read this very well, and because in daily routine while I was working in gynec department in GMC Akola, like my internship time, we were giving labetalol, labet tablet or IV, but IV is preferred most of the cases, and MgSO4 we were giving so that her BP will get decreased easily, and labetalol for its another effects and expedite terminate pregnancy. So it's very important to learn because it's daily routine thing you have to do and you should learn. If you don't know this, you're gonna kill the patient. My ma'am or seniors always, like, they were telling me, if you don't know this, you don't know anything in OBGYN. So now, which of the following tests should be done if polycystic ovarian syndrome is suspected in women with abnormal vaginal bleeding? So we know polycystic ovarian syndrome, in that case there is a dysfunction in ovulation as well as hormonal dysfunction are there. So option from this option, no need to learn everything, only we have to see where the hormones are involved. Platelet counts, no. Prothrombin, no. Coagulopathy, it's not a coagulopathy for sure, we have discussed approach before. So hormone, two hormones. Serum prolactin level, why we will be checking serum prolactin level? There is no need to check it because there is no relation between vaginal bleeding and serum prolactin level. Okay, so serum DHEAS, yes, DHEAS, that is sulfate, I will explain. see. So etiology of PCOS. So first, environmental, genetic, and lifestyle factors will be important. Apart from the chromosome 6 and 9, defects in so this will lead to defects in folliculogenesis, and that will lead to an ovulation. Insulin resistance will be there, and gonadotropin secretion and action. Excess of androgen and production will be there, and there will be obesity that will be affecting PCOS patient, and there will be a difficult thing. So clinical features will be hirsutism and acne due to androgen, testosterone increase, hyperandrogenism, hormonal imbalance will be there, LH FSH ratio will increase, FSH secretion will decrease, and that will lead to that is folliculogenesis defect. Then insulin resistance will be there, insulin levels will increase, and glucose tolerance will decrease. So that's why. And apart from that, reproductive features will be there, that is oligoannulation, that is less annulation will be there. Then irregular menstrual cycle and subfertility can come. Metabolic effect, that is increased risk of metabolic disorders, obesity syndromes will be there. Then apart from that, this is the lab findings. Laboratories we have to check in case of PCOS: total testosterone, sex hormone binding globulin, and morning 17 hydroxyprogesterone and DHEAs can be checked. Remaining this stuff we no need to do. Ratio, fasting insulin, dihydro epiandrosterone, dehydroepiandrosterone sulfate, we no need to do this basically. So here it doesn't come under the diagnosis protocol, but not necessary. But still, if the question asks us, so we have to choose the best options among that, and this question is previous year's question, among the previous year questions. So, and this is probably an old question in recent years, so if they ask sometime, then this is the answer. Apart from that, you should know the Rotterdam criteria for diagnosis of PCOS, two of three criteria after exclusion of the other etiologies. So oligo or annulation will be there. Biochemical markers, test we have to do: testosterone greater than 70 nanogram, androstenedione greater than 245 nanogram per dl, DHEA sulfate greater than equal to 248. So see, Rotterdam criteria also satisfies this. So we have to look at this, but it's not necessary to do DHEAs. We don't do it. Other tests are preferred. Clinical acne, hirsutism, acanthosis, nigricans will be seen according with this. Polycystic ovarian, that is greater than 12 follicles, 2 to 9 diameter in each of the ovary. Ovarian volume greater than 10 cc. This is not a diagnostic, but Rotterdam criteria was given, and previously questions are asked on this criteria, so you have to learn it by heart. Apart from that, for hormonal profile in PCOS, you should know this is the hormonal profile: increased serum testosterone, DHEAs, LDL, AMH, even in obese female, NLH unchanged, FSH, E2, prolactin, TSH unchanged, HDL less, decreased serum progesterone, SHBG due to effect of androgen. Apart from that, this chart is very important. Why I'm saying this? PCOS, you know the diagnosis, you know the diagnostics also, but what about the treatment? So for treatment management, this chart is very easy. So first, start with hirsutism. Hirsutism, we have contraceptives, and spironolactone can be given. Then finasteride is also used, but oral contraceptive and spironolactone is a treatment of choice. Acne, then topical preparations and anti-androgen therapy can be given. Menstruation, dysfunction, oral contraceptive pill, metformin can be used, intermittent progesterone can be given. Then fertility, infertility, clomiphene citrate and letrozole. Infertility, among this, letrozole is very important because it's a drug of choice. Letrozole is drug of choice. Why? I will explain it further. Let's wait. Then obesity, 5 orlistat we use, and other bariatric surgeries can be done. Slip apnea, that is weight loss we have to do, that is more lifestyle modification, and CPAP can be done. Diabetics, that is metformin can be used. Apart from that, other drugs whatever we use according to pharma we have to give. So endometrial cancers, oral contraceptive, intermittent progesterone can be given to endometrial cancer. So intermittent progesterone effect will decrease the cementing, so intermittent progesterone we have to give, and the cementing effect will be there. And once at the as we taper the dose, progesterone effect will get loosened, and then the endometrium or the extra lining will come outside. So for that treatment, and we have 9: insulin resistance, cardiovascular risk, metformin, and metformin only. So let's move to this slide. So this is very important. Letrozole, why letrozole is a drug of choice? This is a question that is live birth rate. Live birth rate is increased. That is, live birth rate is very high with this. So that's why we use. And apart from that, it's well tolerated. It's well tolerated. No antihistaminic side effect is there. Headache is rare. But with clomiphene citrate, there is a hot flashes most common side effect, and vaginal dryness is there, and live birth rate is also compared to less. That apart from that, you should know the mechanism of action of these drugs. So this is the one more MCQ. You should learn this. Dose, no need to learn because it's not that much asked. Apart from that, uses ovulation induction, we use clomiphene citrate, second drug of choice in PCOS, but for ovulation induction, we use clomiphene citrate. Drug of choice for PCOS is letrozole, and letrozole. Contraindicated. These both drugs are contraindicated. One more question. Contraindicated in Sheehan's, pituitary ablation, hypogonadotrophic hypogonadism, and Kalman syndrome. Now, this is another table. So this was old table to learn the stuff, but no need to, because I have made it easy from here. This is very easy to approach for treatment now. Just you have to learn your pharmacology well, and after this you read this table. No need to learn the drugs also, because it will be very easy in your mind to do that. So now, question number 27. What are the 4 risk factors of PPH arising during PPH? So this is PPH question, and it's very difficult to answer without knowing the facts. So let's come to the facts. So facts are like this. Risk factors for postpartum learned by partum pneumonic, P for polyhydramnios, A for antepartum hypertension, R for recent bleeding history, T for twins, and U for uterine fibroids, M for multiparity. So this, if you learn, you can solve this question. Let's solve the question first, and then we will move for up. So previous PPH, yes. Polyhydramnios, yes. Multiple pregnancy, yes. Multiparity. Anemia conditions, so yes, possibly. Let's see the another option. Abruptio placenta, no. No. Iron deficiency, no. Intrauterine death, no. Abracadabra placenta, no. Previous PPH, yes it is, but iron deficiency, no for sure. Placenta previa, no. Polyhydramnios, yes. Outer uterine death, no. ANC, so ENC, E, that is ANC, A and C. A is there, but not C. Abracadabra, what is this? So A is the answer. This question was asked in FMG. So I have taken according to my research. So that's the answer from this chart. Now let's discuss this approach towards postpartum hemorrhage. Very important, because by this you can diagnose different diseases. So let's see. Again, the algorithm starts same. Patient present to postpartum hemorrhage, unstable. We have to do management, that is C, A, B, C, D, E management. Apart from that, assess time for delivery. So let's divide this chart into 2 parts, A and B. Let's discuss the A part first. Let's discuss the A part. So for A part, delayed hemorrhage greater than 24 hours to 12 weeks of postpartum. Focus on history and physical examination. Labs, CBC, PT, PTT, INR, and passage of large clots will be there in postpartum hemorrhage. Delayed postpartum hemorrhage, prolonged intermittent gushes of heavy bleeding will be there, and saturating greater than equal to 1 pad an hour will be there. So let's discuss the cases 1, 2, 3, 4. So first case, no fever, no uterine tenderness on history and examination physical. Labs, the anemia plus minus can be there. Normal coagulation studies are given. Consider retent product of conception in this case. Retent product of conception. Then we have to do pelvic ultrasound. On pelvic ultrasound, if you see thickened heterogeneous endometrium plus minus mass endometrial cavity, then it's a retained product of conception that can be diagnosed. Questions are asked. Options, most of the time there are options like retained product of conception, endometritis, inherited coagulopathy, another option, and they ask a postpartum hemorrhage case. So you should be ready to answer these questions very well. That's why I'm doing this approach for this lecture. Now, if fever is there and examination shows, physical examination, elevated temperature, uterine tenderness, and malodorous vaginal discharge, the labs should be done. On labs, anemia may be present or may not. Leukocytosis with left shift is given if positive. In that case, endometriosis should be diagnosed, and temperature. Infection is equal to temperature most of the time. Apart from that, you have to check the leukocytosis, CBC. So CBC, that's why we do CBC, PTINR, and LFT-KFTs and other tests while our internships. So very boring, but we have to do it. So another history where history can be there of heavy menstrual bleed, family history of bleeding. So family history, inherited cause of coagulopathy for short. So anemia may be there, and PTINR we have to do consider inherited coagulopathy, pelvic ultrasound, normal ultrasound, genetic testing, positive inherited coagulopathy. This is the answer. Now after assessing the common causes of delayed hemorrhage, consider less common diagnoses like subinvolution of plasmaticide, neoplasia, vascular malformation, and hyperestrogenism. Now coming to the part B, that is part B of this chart. Let's see what's in the B chart. So less than 24-hour hemorrhage, that is immediate hemorrhage. Focus on again history and examination. CBC, PT, PTINR, fibrinogen. So profuse bleeding history is the high parity, prolonged oxytocin use, intra-amniotic infection, multifetal gestation, and precipitous delivery. So if this type, among this at least 3 or 2 also there, then we can go towards PPH algorithm. So assess uterine tones then. So evaluate uterus and perform bimanual examination. Finding soft and boggy uterus if there, then uterine atony, that is one case, uterine atony case, boggy and soft uterus, uterine atony. Now going to further in this chart, that is assess obstetric trauma. Now obstetric trauma, examine perineum. Obstetric trauma, we can examine the perineum, vulva, vagina, and cervix. Findings: disruption of vagina or cervical tissue, is trauma bleeding from vaginal or cervical mucosa, trauma, cervical laceration, again case, that is one more question, vaginal or cervical laceration. Findings: if there is collection of blood in vagina or vulvar, soft tissue is there, tense, painful, comprehensible mass is palpated, vaginal or vulvar hematoma will be there, another case is solved. Again, these are the options given in MCQs, so you have to know the diagnosis for this. That's why this approach I have taken for this time's high questions. Assess for retained tissue. Now by manual examination plus minus bedside ultrasound, fast can be done for sure. Findings: placental hemorrhage is there, or tissue extracted on exam. Ultrasound shows echogenic or heterogeneous material within endometrial cavity, so it's a retained product of conception. Diagnosed. Then we are assessed for coagulopathy, that is thrombin, you have to check. Review lab results again. Low platelet may be there, low fibrinogen may be there, prolonged PTINR greater than 1.5, prolonged PPT. So coagulopathy should be diagnosed. Continued significant bleeding is there. Repeated evaluation, monitor vitals. So this laceration case we will discuss further. Now let's move on to the next question. Next question is the 28 number question. Let's move to this question. Continued bleeding occurs during the third stage of labor with contracted uterus. The most likely cause is cervical and perineal laceration, placental abruption. Placental abruption is no. Uterine atony, cervical polyp. It's not. Cervical and perineal laceration from these two. So you must, like in hurry, we tend to mark uterine atony boggy, but their uterus is boggy, but they're asking continued bleeding. Continued bleeding is in case of active bleeding. Active bleed equals to trauma, obstetric trauma, so it is cervical and perineal lacerations. This is a discussion. Then 29 question. So maneuver. Coming to the maneuver questions, there are only 2 maneuvers. They are most commonly asked always. One is McRoberts and another is Leopold's. So Leopold's I am not discussing, it's very kind of easy and you must have done it lot of time. But McRoberts maneuver, why I am taking, during my exam FMGE 2024 Jan, it was asked. NEET PG, it is asked recently. So we and ionicity also they ask, but the format of question is different in different. So I have taken 4 to 5 questions on this topic because in each exam it asks differently. So which of the following maneuver involves hyperflexing mother's leg tightly to her abdomen to widen the pelvis and facilitate delivery in the shoulder dystocia? Shoulder dystocia, it's McRoberts maneuver, but let's discuss how it is. So whenever there is shoulder dystocia, be calm. So breathe. Let the patient tell patient to breathe. Do not push. Low head of bed. The head. Elevate legs into McRobert position. Sharp hip flexion while supine position. Call for help. Apply suprapubic pressure. Downward lateral to release anterior shoulder. So this question will be there. Enlarge vaginal opening with episiotomy to facilitate extra maneuver. Episiotomy can be done. Maneuvers. Delivery of posterior arm. Pressure against baby's posterior shoulder either anteriorly or posteriorly, and anterior rotation would corkscrew or Rubin maneuver. This is mother on hand and knee, that is all fours like a chair. Replace baby's head to vagina followed by cesarean section. It's a Zavanelli maneuver. One more question, that is now this chart you have to learn. Mnemonic. I am not good with mnemonics, but still I have given that. I never learned this because I diagnose the case and go according to my instinct. So this is McRoberts maneuver. Knee pull towards the chest. This knee pull towards chest. Suprapubic pressure is given, applied. Then pelvis is tilt, orienting pubic symphysis and sacrum more horizontally to facilitate shoulder delivery. Then gentle traction of head should be done. And now coming to the question. So this is our question. So it's McRoberts maneuver. We are done with that. The part of baby given suprapubic pressure in this. So this is the factual question asked a lot of time. Anterior aspect of anterior arm should be given suprapubic pressure. Learn this anyhow. Then McRobert and suprapubic pressure ineffective. Which of the following will be there for women? All fours. We have to perform all fours. You have to just learn it by heart. Now this is 32 question, I guess. Which of the following is the most common injury to the baby in case of shoulder dystocia? This is also a lot of time asked question in anatomy. If you know the anatomy, you can ask this question easily. Hypoxia, ischemic brain injury, no relation. Death, no relation. Brachial plexus, yes. Why? Because shoulder and brachial plexus goes together. Humerus and clavicle fracture can be there, but brachial plexus injury is the most common. Now this is the explanation. Read it. Now which of the following is the smallest pelvic diameter at being? So pelvic diameter are asked a lot of time. This is NEET PG 24 recall question as well as INICET recall question. So which of the following is the smallest pelvic diameter at being? Before that, smallest is obstetric conjugate for sure, but you should know this table for solving that question. True conjugate is 11 centimeter, obstetric conjugate 10.5 smallest. So here is the one question is asked most of the time. You have to know two things, that is smallest and the largest. Largest is the transverse diameter in AP 13. So one more question. Oblique diameter 12 centimeter. So learn these facts and you will be able to solve this question. Apart from that, this is asked a lot of time. So let's see this. So the submentobrachmatic length 9.5 and face presentation submentobrachmatic. This is the submentobrachmatic and for face presentation 9.5. So AP diameter always longer than transverse diameter. This is the hook. Longest AP diameter is mento-vertical diameter. Mento-vertical diameter is the longest one, 14 centimeter. Brow presentation requires C-section. So one more question is done. From this brow presentation, we do C-section cannot pass from maternal pelvis. Second longest AP diameter is submentovertical. So in green, 11.5 face presentation, and submentovertical occipitofrontal and occipitofrontal. The second longest in vertex presentation. Other vertex And then we have transverse diameter smallest to longest, that is bimastoid, bitemporal, supersubparietal and biparietal. Most common engaging diameter is biparietal. On this question as asked, so you have to learn bimastoid is the smallest, and this is the thing, biparietal and all. So I guess that's all for this session. Apart from that, this PDF will be available on my telegram channel. So I will be sharing that on my telegram channel. So let's meet there. Apart from that, on telegram channel I will be adding all the other high yield topics names, because it's very highly impossible to discuss each and every topic, but I have discussed the most commonly asked questions and most commonly asked topics and from high yield topics. So let's come to the last slide. Thank you for your attention, and thank you. Hope the response on this video will be good. I know that it's very difficult to succeed every time, and that's why this quote I have taken. This is by SRK, because I adore him a lot. Success and failures are both part of your life. Both are not permanent. So success, those who have got success in first attempt, it's not permanent. We have to prove ourselves again in NEET PG the exams. And those who haven't got success, that's also not permanent. You have to work hard, and there are 30 days left to our exam. So work hard and keep studying. Thank you for your attention. See you with next video on another topic and lot of high yield MCQs.